so we have, one of the newer things we've debuted here recently is this sort of optical surface mapping. I thought about putting that in here today. I didn't want to run overboard, but it's a really cool technology that, may have some use in breast cancer. More going to be probably patients with maybe breast cancer metastases where we're treating other areas, but where we can actually see what's happening during radiation.
Wow.
We take a lot of care to set them up before the treatment, but then once we leave the room and the beam comes on, that we have them immobilized with masks or back locks and different things like we showed in those pictures, but they can still wiggle a little bit. But this kind of what it does is, analyzes the patient's surface anatomy and uses like an AI algorithm to tell us if they move too much or not. And then it can give our, Ellen and other ones or other therapists an opportunity to turn the beam off and stop. Hey, you moved a little too much. We're going to stop this beam because it's going to maybe hit something that we don't want it to hit. So that's one of the cooler things that we've debuted recently. But yeah, our field, it's very technology heavy, so stuff's always coming out.
Yeah, thank you. Sounds like an entirely different presentation.
Exactly. Yeah,
Very
that's
interesting.
We could do the whole talk on that. I really appreciate everyone who asks questions. That makes these talks so much more enjoyable for us, and I think so much more informative. So really, thank you. I really appreciate it.
Thank you as well. We appreciate you and we appreciate the presentation. So we are going to transition to a brief break. And so during this time, we ask that you stay signed on. Please keep your computer muted though. Check your CME account and attendance. And then we will plan on reconvening at 1 o'clock with Dr. Amy VanderWoude. So take this opportunity to drink some water, get up and walk around, grab a bite to eat, and we will see you at 1 o'clock. Thank you all.
Yeah. Are you good?
Yeah,
Okay.
I am.
She's all set up.
okay.
I'll be in there.
Thank you. Welcome back, everyone. Hope you enjoyed a short break. For those of you that are just joining for the second part of our symposium, next up we have Dr. Amy VanderWoude. Before we get started, just review a couple of housekeeping items again, for those of you that may not be as familiar with the process regarding CMEs as well. So please make sure that you mute your phone, turn off your video to help with bandwidth, and you can pin Dr. VanderWoude by just right-clicking on her picture, and that will provide you the pin option. For those of you that are claiming the CME credits, please complete the sign-in process through the Cloud CME mobile app. The text code for today to record your attendance is 31803. And then that will allow you to complete the survey as well and collect your education credits. And if you do have any questions outside of that or need any assistance, you are more than welcome to reach out to Catherine Williams, or you can reach out to me as well. So I'm going to go ahead and introduce Dr. Amy VanderWoude. Dr. VanderWoude is board certified in hematology and medical oncology as part of the leadership team at Cancer and Hematology Center of West Michigan, and serves as a leading provider for breast cancer multi-specialty teams, breast cancer treatment, chemotherapy infusion, and clinical trials. She holds an undergraduate degree from Duke University, a graduate degree from Wake Forest School of Medicine, completed her residency at the University of Michigan Hospitals and Health Center, as well as fellowships at both the Dana-Farber Cancer Institute and Brigham and Women's Hospital. Over the years, she has delivered excellent care to our patients as a provider with our Spectrum Health team. Please join me in welcoming Dr. Amy VanderWoude to discuss medical oncology and the side effects of treatment. Happy to have you, Dr. VanderWoude.
I don't think she's. 1 minute, we're getting set up.
You're okay. I know this presentation is going to be worth the 1 minute wait.
Well, I think you can hear me, but you can't see me. Do you have anything on your end that you can click for the visual?
I do not. Is Catherine in the room with you right now?
Yes.
Okay.
Share the screen and we might be good.
You are more than welcome to join me in my space, and I will put my mask on, if that would be helpful.
Let's give it 20 seconds.
Okay.
And if we can't. Now, do you see the slide?
Yes, I do.
All right. Well, I think we're good then.
Great. Thank you.
So thank you so much to the symposium committee for inviting me to speak today. I think the topic that I was asked to discuss is medical oncology, treatment side effects. And so that's a pretty broad topic, and I'm speaking to a broad audience. I know that there are some medical oncology providers out there, primary providers out there, also patients and their caregivers. So I'm going to touch on a few specific points, but I think before we get into all that, I really want to just give a little bit of background about medical oncology and cancer treatments in general. So when I think about how we treat cancer or how we design a treatment regimen for a patient, there are really three what I call pillars of cancer therapy. So there's surgery. Most people know what that is. Radiation oncology, you just heard from Dr. Packard and know what radiation oncology is now. And then medical oncology. I'm a medical oncologist. Now, the first two issues, surgery and radiation oncology, are what we call local therapies. They work in a specific area. So they work where you put the scalpel, they work where you aim the beam. And so they take care of cancer in a specific area. So medical oncology, what we do, we deliver systemic therapies. So it's complementary to the local area. We often need some treatment for the rest of the body, be it to treat low-level invisible cancer that we want to eradicate or cure, or to control cancer that may have spread from where it started to another area. So we do something a little bit different than the surgeons and radiation oncologists, and we work together to design that cancer treatment. So when we're thinking about the cancer treatment that a patient's going to have, or what you as a patient are going to undergo, there are different goals of the treatment. So sometimes it's curative therapy. You're trying to get rid of the cancer so that it never comes back. Other times when we start with the treatment, we already know that we can't cure it, but we want to control it. And we want to help you as a patient live longer and have a better quality of life during that time. So there's two very different goals of therapies. And if you as a patient aren't sure on which goal is your situation, then certainly ask your providers about that and have them clarify that. So when I say systemic therapy, what does that mean? So that means it's treating your system, your body. And most systemic therapies are going in through an IV or your port, but there are also some pills that we use. But there are a lot of different types of systemic therapy these days. So most people think of chemotherapy when you think of a medical oncologist. So chemotherapy drugs are drugs that go in and kill rapidly dividing cells like cancer cells. Now, unfortunately, we have some bystanders that are hurt with that too. So our hair is rapidly growing. So that's why that sometimes comes out with chemotherapy. Also, your mouth and your gut can be lined with rapidly dividing cells. And that's why some chemotherapies cause mouth sores or diarrhea. And also your blood counts, of course, are always being replenished. So your red cells that carry the oxygen, your white cells, your platelets that help to clot blood. And that's why they go up and down with chemotherapy. But there are a lot of other treatments that medical oncologists use to treat cancers. There are hormonal therapies. So patients specifically with breast cancer and prostate cancer take pills or have injections to decrease or fight against the hormones that can feed that cancer. There are targeted therapies, and there are a number of different treatments in the targeted therapy category. You might say hormonal therapies are targeted therapies because they target the estrogen receptor or the androgens in the male body. Other targeted therapies would be, one of the first ones was a tyrosine kinase inhibitor. It's a pill that revolutionized the treatment of CML. It's called imatinib or Gleevec. And there have been a lot of other targeted therapies, including monoclonal antibodies like the trastuzumab, also known as Herceptin or Kanjinti, which is very active in the treatment of HER2 overexpressing breast cancers and also some gastric cancers. Rituximab or Rituxan that we use to treat not only lymphomas but benign hematologic conditions. Some of the monoclonal antibodies like bevacizumab or Avastin, cetuximab, that are used in the treatment of a wide variety of cancers. So there are a lot of different targeted therapies. And then finally, most recently, the immunotherapies that you see advertised on television, which help the body harness its own immune system to fight against the cancer. The most common ones would maybe be nivolumab, also called Opdivo on the television, or pembrolizumab, also called Keytruda. So there are a lot of different therapies that medical oncologists use in an effort to help treat, maybe cure, or control a cancer. So again, my talk is about the side effects of cancer therapy. So now you can see why it's so broad, but I can really divide them into two different categories. Most people, most of you are probably thinking, oh, I know what those side effects are. The hair comes out, you throw up or feel nauseated, or the blood counts can go down. Those are acute side effects that occur during the course of therapy. And they usually get better within a couple months of finishing therapy. But what I really want to focus on today, this is a survivorship focus for this symposium. So I really want to talk about some of the chronic side effects of cancer therapy that survivors deal with and can persist for months or even years after completion of therapy. It can really affect their life, and it can affect the life of their caregivers and their families. So I want to focus on them a little bit more. So here are some of the chronic side effects that our cancer survivors deal with. And this is by no means exhaustive. There are other things as well, but these are some of the more common ones. Neuropathy, a numbness and tingling in your fingers and toes from your chemotherapy, which can be painful and can lead to balance issue. I'll touch on that quickly. And then the psychosocial aspect. So that's the mood, the anxiety, the depression that comes with a cancer diagnosis and its treatment, and even the surviving of that cancer or living with it. Sleep disturbance, fatigue, cognitive dysfunction. So that sometimes is termed or nicknamed chemo brain, but we'll talk a little bit later about the fact that it may not relate solely to chemotherapy. There are other things that I'm not really going to touch on as much because they affect maybe more discrete patient populations and also because of time, but sexual dysfunction, fertility issues, the side effects of the hormonal therapy that breast cancer and prostate cancer survivors are prescribed, the bone health, the decrease in the bone density that can occur from some of our treatments, the cardiac dysfunction that you'll talk about tomorrow with Drs. Franey and Abdullah, the pain that some patients are left with, and lymphedema, a swelling in a limb or an organ from removing the lymph nodes for the treatment of the cancer. So I'm going to, as I said, briefly talk about neuropathy and then move on to the others. So neuropathy is especially common with treatment of breast cancer and colon cancer, but also can occur with other treatments. It has to do with the medicines we use, usually chemotherapies. And it's a numbness and tingling in your fingers and toes. It usually starts in the tips and then moves down towards the wrist or the ankle. So they call it a stocking and glove distribution. It's mainly sensory, meaning that your muscles work okay. You can walk okay, you can move your hands okay, but you can't sense things as well. It usually gets better with time and will resolve if it doesn't cross a certain point. But if it is significant and becomes painful, then patients can be left with that, and that really can affect quality of life. The drugs that you see causing this most often would be the platinum agents like cisplatin, oxaliplatin, used in lung cancer, ovarian cancer, colon cancer. The taxane drugs, paclitaxel, which is also called by its brand name Taxol, or docetaxel, also called Taxotere. The vinca alkaloids that we use in the lymphomas, the vincristine and vinblastine, and then bortezomib, which is also called Velcade, is the brand name, and that's used for myeloma and other hematologic cancers. So why are we worried about neuropathy? Well, one, as I mentioned, it causes pain, but two, it can cause functional limitations. If you can't feel on your feet, then you can lose your balance. You can fall and hurt yourself. So how do we treat neuropathy when it occurs? Well, by far the best approach is prevention. These are necessary medications to treat a cancer, but if we dose reduce or we dose delay, take a break, or maybe even both, that helps prevent the progression that can happen as you go through. So again, this is cumulative, unlike, say, nausea, which might happen each time, but it doesn't build up each time, it's just repetitive. The neuropathy can be cumulative, so we have to pay attention to it. Once it occurs, though, if it's bothersome and it's painful, physical therapy can be very helpful, specifically balance therapy, so it can help the patient to learn to prevent falls. If it's painful, then the medication that the National Comprehensive Cancer Network recommends is Duloxetine. The brand name is Cymbalta. So for the providers in the audience, you start at a dose of about 30 milligrams daily for about a week, and then you move up to 60 milligrams daily. It tends to be fairly well tolerated. There are also, that big paragraph at the bottom talks about other things, and in there you'll see acupuncture. And we have acupuncture available at Lemon Holton Cancer Pavilion, Spectrum Health. The hard thing about acupuncture is sometimes it's not yet covered by insurance, but we're working on that. Some of the older antidepressants like amitriptyline and nortriptyline can be helpful. They make you sleepy, so you give them at bedtime. You'll see that gabapentin, which is also called Neurontin, and pregabalin, which is also called Lyrica, are no longer recommended by that task force, but I have a number of patients on them and it can be very helpful. So, and then there's some compounded creams that can blend medications together. You have to find a compounding pharmacy to make that, and sometimes it's hard to get it reimbursed by insurance, but they can be helpful. So I want to move on now to the other 4 issues that I had starred on that long list: psychosocial functioning, the fatigue, the sleep disorders or disturbances, and the cognitive functioning that survivors experience. These are very real things. They are very common things. I think as a patient, you'll know that this happens and you may be experiencing some of these as a survivor. As a caregiver, I think sometimes caregivers are wondering, when is this going to get better? Or is my loved one within the normal, or can't they get over this? And I think as care providers, we often have a lack of understanding or a lack of knowledge about how prevalent these are, and also what to do about them to help a survivor. So we're going to talk about some of these things. I think the other thing is they're interrelated. You know, when you have one of these, there's often another. If you're depressed and anxious, you may also not be sleeping well. You may not be functioning well at work. And so it's really important to try to address all the issues that are affecting our survivors. So for psychosocial, that means the emotional concepts or the depression and anxiety that patients sometimes experience or often experience. I think that's probably 100% at the time that you're diagnosed and you're going through the treatment, but then lingering, 3, 6 months after or years, patients still deal with these issues. So the Institute of Medicine, when they were talking about survivorship and addressing it, described distress as a multifactorial, so multiple reasons, unpleasant experience of a psychological, so that's your cognitive, your thinking, your behavioral, your emotions, but also social, spiritual, and possibly physical nature that interferes with one's ability to cope effectively with their cancer, the physical symptoms that the cancer and the treatment are causing, and its treatment. So that's a very comprehensive diagnosis or definition of psychosocial stress imposed by cancer. A lot of it focuses on the fear of recurrence. That can really negatively impact the quality of life of a survivor. But it can also focus on other things, and we can talk about that in a minute. The reason this is important is not only it decreases the quality of life of both the survivor and their caregivers, but also survivors have been shown that they're less likely to engage in the recommended surveillance, your doctor's appointments, if you need scans or blood work, and also the health promoting activities, exercise, healthy diet, smoking and alcohol cessation. So psychosocial stress decreases their adherence to these things, and so their outcome can be different. There's also an increased rate of anxiety and depression, even post-traumatic stress disorder, or even suicide in cancer survivors. So this is something that needs to be assessed and readily addressed for our patients. What contributes or who puts a patient or what puts a patient at risk for prolonged psychosocial stress? Physical limitations. They can't do what they used to do. Maybe physical signs of their cancer. Maybe you had a limb removed, an amputation, or a breast removed, or maybe you have a colostomy bag that constantly reminds you of the experience you've gone through and the fears you have surrounding that. Also, non-white race, low educational, financial, or social support, unmarried status, and having survived multiple primary cancers can be risk factors for continued ongoing psychosocial distress. So what do we do about that? Well, first, address the things that are playing into it that you can. If the patient as a provider is not sleeping well, if they're having pain, if they're fatigued, address those issues. If they have other health issues that need to be optimized, their thyroid function or if their liver, their kidneys, their heart, their lungs are not functioning well, get them to the right specialist. Offer reassurance so that they know that it's an appropriate response and that they're not the only ones experiencing this. Provide information for resources to engage with other people through social networks, Gilda's Club, through the church or emotional, spiritual needs. Address intimacy issues. We have a sexual health and menopause clinic here for the women who have sexual dysfunction after their treatments. And try to address the physical activity. And this is, I want you to notice this, each time I talk about a topic is one of the things we some trials have said that physical activity, meaning exercise, is as effective as antidepressants in treating the anxiety and depression that our survivors experience. Counseling, psychotherapy is helpful. And then, of course, pharmacologic therapy, that means medications, are used frequently in this population. In fact, they're used twice as frequently in the cancer survivorship population as in the general population. That's because they're helpful. And that means antidepressants and sometimes anti-anxiety medications. Now, this is a clinical pearl for the clinicians in the crowd. For women taking tamoxifen, so these are women with breast cancer, most of the antidepressants will interact with tamoxifen. It would not hurt a patient to take them together. There wouldn't be a detrimental side effect, but the tamoxifen won't get broken down to the active agent endoxifen. So if your patient needs an antidepressant, and that's common, then the ones you want to pick from are escitalopram, also called Lexapro, citalopram, also called Celexa, and venlafaxine, Effexor. Escitalopram and venlafaxine are particularly good choices because I think any survivors of breast cancer out there on treatment will tell you that hot flashes can also be problematic, and those medications are pretty effective in decreasing the hot flashes as well. I prefer escitalopram because it's a little smoother. The venlafaxine, as you know, if they miss a dose, they can have withdrawal symptoms. So let's talk about sleep disturbance. This is really prominent for cancer survivors. 30 to 50% of cancer survivors experience some form of sleep disturbance. So what does sleep disturbance mean? Well, it can be insomnia. You can have trouble falling asleep, or you can have trouble staying asleep. You might wake up and can't get back to sleep. You can feel very tired during the daytime, but there are other things that can happen too. So sleep-related movement disorders like restless leg syndrome. Here's a clinical pearl, tamoxifen can cause that. And we'll come around to that and talk about that a little bit in a minute as well. Or breathing disorders. So you can have obstructive sleep apnea, either from obesity or other medical problems or surgeries you've had to treat the cancer. The other things that can bother sleep, as we know, it makes sense, but poorly controlled pain. If you're excessively fatigued, sometimes sleep is difficult. Anxiety and depression. So those things, again, are all interrelated and need to be addressed for our survivors. When you have better sleep, you feel better. You have better energy, you think better, you have better mood. And so it really is vital to address this and treat it. It's likely multifactorial. They don't know all the causes of sleep disturbance for cancer survivors. But again, we know that you feel better if you're sleeping well. So what do we do about sleep disturbance? Well, simple steps to begin with. First of all, if there are other problems impacting the sleep, again, the pain, the fatigue, the emotional distress. Also, if there are other medical issues like thyroid dysfunction or breathing trouble, you want to address that. If there's alcohol or substance abuse, address that. And then talk about the sleep hygiene. It makes sense, but sometimes when you're not sleeping well, people start to nap during the day and they get turned around. They can't sleep at night then. So really what the experts recommend is regular physical activity. There it is again, physical activity. Exposure to daytime bright light and then a dark sleeping area. So they're very different. Avoid the heavy meals, the strenuous exercise. We want you to exercise, but not right before bedtime. Avoid alcohol use. Don't watch an action-packed movie right before bedtime. So those things are very necessary, but they're not usually sufficient to fix the problem all by itself. Increase the physical activity, have the therapy, And then sometimes we have to use medications, although it doesn't really, the data does not really suggest using sleep medications as a patch to just help survivors sleep. Remember as a provider that other medications like narcotics, antihistamines, antidepressants can all contribute to the sleep disturbance. And I think it's important for our survivors to really minimize the number of prescriptions that we prescribe if possible. Check for obstructive sleep apnea. If you're suspicious, send them for a sleep study. Check for the restless leg syndrome. So we're coming back to that. I mentioned that it can be associated with tamoxifen therapy, but it can also be associated with iron deficiency. So check the iron stores. And if that's the issue, replete them. Otherwise, there can be effective medication for restless leg syndrome. Pramipexole, which is also called Mirapex, ropinirole, which is also called Requip, or some of the other medications listed there can be helpful. So let's talk about fatigue. Most cancer patients feel tired, almost all, I would say, during the course of therapy. But it's astounding to know that about 1/3 of cancer patients will have continued fatigue that persists for a number of years post-treatment. And I think a lot of providers don't realize that. A lot of family and caregivers don't understand that a patient can really truly be fatigued. And it's a different fatigue than we experience at the end of the day when we don't have cancer. It's persistent and it doesn't really help to rest. But it's really stressful for both patients and family members, both in social venues and at work, trying to perform at your pre-treatment performance. And some patients will say, if I could get one thing fixed, it would be the fatigue, more than nausea, depression, or even pain. So it's a really important topic to address with patients. It probably has multiple causes. You know, the chemotherapy certainly can cause it, or the treatments that we give. Radiation can cause fatigue. A poorly controlled cancer that's progressing can increase the fatigue, but so can pain, so can anxiety, so can depression. If you're not eating well, if you're not drinking well and you're dehydrated, if you have other cardiac or pulmonary, liver or kidney issues, certain medications contribute to fatigue. If you're just not in shape, that's called deconditioning. They can all contribute to fatigue. So one of the things we need to do is educate the patient and family about the fatigue and how it's different, so that when a patient tells a loved one, I really am tired, they need to look at that differently, understanding that it's not all under their controls. Again, identify the causative factors and try to address what you can address. Treat the pain, the anxiety, the shortness of breath, the mood, and refer to specialists as needed. These are some of the many interventions that you can use for fatigue. But look at number 3, exercise. Comes back to the exercise. Certainly there's some medications that I probably wouldn't prescribe, but maybe a counselor might prescribe if they feel it's appropriate as stimulant, like Ritalin or modafinil. And now finally, we want to talk about cognitive dysfunction. Cognitive dysfunction is sometimes termed chemo brain, but it means that you're having trouble processing. Maybe you can't remember things. Maybe you used to walk down the hallway at work and 2-3 people would say, can you do this? Can you do this? Yep, I'll do it when I get back to my office. And then you get back and you can't remember anymore. Or you can't process or comprehend things as quickly. Or you can have difficulty with complex attention, like staying focused on the task and finishing it, or reading something or really understanding it, or verbal learning when people are talking to you and you have to comprehend it verbally. You don't have a picture, it's not written. Visual spatial abilities to embed, and executive function. Executive function is understanding what you do now may impact something in the future, so thinking that through. So cancer patients are about 40% more likely to report memory problems than those without cancer. But interestingly, when they've done some studies, they've seen that the deficit is really there prior to the treatment. So maybe it has a little bit to do with the diagnosis itself, or perhaps there was a baseline dysfunction, and then when you give the treatments, it makes it worse or more obvious. So it's not really appropriate to call cognitive dysfunction related to cancer treatment chemo brain, but we do know that those things can certainly impact it, and it is a very real thing. The mechanism is not well defined, so it's a little harder to evaluate it and treat it. But again, there are those things that we can evaluate: pain, other medical issues, anxiety, depression, menopausal side effects for women. So what do we do when we're trying to evaluate that? Well, first, rule out the reversible treatable factors that I just mentioned. It's important as a provider, if there's a focal neurologic deficit, meaning for the patients, meaning that maybe one arm is weak or there's a visual change or something, make sure that there's anything going on. A cause would be something maybe in the brain that could be causing it. So make sure the cancer is not contributing to this. And then if the symptoms persist greater than several months after you finish your treatment, that's when it's time to start thinking about, well, how much do they impact the quality of life? Are you really not able to function, or are you just reporting something that is definitely a new thing? You can't remember everything, but you're able to function. So if there's great concern, then you need to refer for neurocognitive testing. The other things that can be helpful are reassurance, because it doesn't usually get worse and worse over time. It starts to get better, or it might persist. The behavioral approaches like relaxation techniques, physical exercise, there it is again. Some of the nerve stimulatory things like TENS units can be sometimes be helpful. Cognitive rehabilitation, brain training, and then sending again for the neuropsychological evaluation can be helpful. There are some medicines that sometimes specialists will prescribe, like modafinil for Provigil, or methylphenidate like Ritalin. And probably a combination of all these things is best. So that's where I'm going to stop for a minute. These are real things for our patient survivors. There are many other things, and I'll touch base on the things listed on this slide that we didn't touch base on, and the support for them in a little bit. But I think we could take questions if there are any.
Please feel free to put your questions in the Teams chat, and I will monitor those, Dr. VanderWoude.
Well, thank you very much, Amy, for this great presentation, and hopefully people joining us on these calls appreciate the complexity, and as you said, you're absolutely right. It doesn't end when the treatment ends. It's an ongoing risk and sequelae of treatment. But just a quick question: are you aware of any studies exploring actually moderate exercise during therapy, during cancer chemotherapy, to minimize long-term effects, especially physical effects?
Yeah, there are some studies supporting that, and we're always trying to encourage patients when they're going through their acute therapy to exercise as much as they can. You don't have to go out there and run. You can walk, just walk as quickly as you can and walk as long as you can. And it really helps them tolerate the treatment during the phase of the acute side effects when you do have nausea and fatigue. But also that has to become a part of the lifestyle afterwards for survivors. It really helps. And it helps a lot of things. It helps the mood, it helps the energy level, it helps the sleep, it helps side effects for breast cancer survivors, it helps the side effects of your treatment, it lessens the achiness that some of your pills cause, it lessens hot flashes. And for breast cancer, at least, we even know that it decreases the chance of the breast cancer coming back. So that's a good point and really important.
Thank you.
So we do have a question here from Catherine. Have there been negative outcomes noted because patients have not been able to have their families present during treatment and have felt isolated during treatment due to COVID? And then any recommendations to help cope with the lack of social engagement?
Well, COVID has been a difficult experience, especially in our office when patients are coming for something that's very stressful, like chemotherapy, and there were limitations on who could come in with them just to protect them and other patients as far as the infectious risk, especially when testing wasn't widely available. I have not seen the trials come out yet to say that there was a definite detriment in their cancer outcome, but certainly the psychosocial stress that patients experienced we were able to allow somebody to come with the patient for their first chemotherapy treatment, but normally we can let somebody come each time to be there as a support, and we haven't been able to do that. And that does cause a lot of stress. And I think the social isolation as well, whether or not you're a cancer survivor or a cancer patient, the social stress has been hard. The isolation has been hard for a lot of people.
Andrea has a question. I was under the impression chemotherapies work best in a body that is fully oxygenated. Is that true? And if so, what can patients do to remain oxygenated? Quitting smoking is one thing, but are there other activities they can do to keep their bodies optimized for the chemo to work most effectively?
I wouldn't say it has to, I think it works. I wouldn't say you have to be oxygenated to have the optimal effect of chemotherapy. It does go in, and it's going to go through the bloodstream and get to hopefully where all the cancer cells are. Whether or not chemotherapy works is a little bit a function of the cancer itself and how aggressive it is or has become. But we know that, adequate oxygenation as far as breathing is important. And if somebody's having a problem, we certainly want to address that anyway. I think that exercise has multiple effects on the body to help it not only tolerate the chemotherapy or any treatment you're receiving if it isn't chemotherapy, but also to help control the cancer. And I think we're learning more and more. That's a wide open area of research right now of how does exercise impact cancer treatment and help control cancer. So I wouldn't say there's not anything specific, i.e. wearing oxygen during therapy, that would help with the chemotherapy, but it is important to make sure somebody has an adequate oxygen level, and if not, evaluate why.
Yeah, I know that there are other healthcare systems that utilize walking, for example, and I'll just share about breast care patients because that's an area of interest for me, but where they have treadmills available for the patients, and they're walking while they are receiving their infusion. And over the last probably 6 months now, have had an opportunity to do a pretty extensive lit review specifically related to early diagnosis breast care patients, and the overwhelming positive effects surrounding moderate aerobic exercise, and then of course strength training we know is very important too, particularly for our bone health. But there is a lot of evidence that supports, and looking forward to partnering with you and Emily Parker and your team, Dr. VanderWoude, on implementing such a program here for that very population.
Absolutely. Exercise just keeps coming back into the picture. And if you're a survivor and you're out there, do your best. We know that everybody can't get out and walk 2 miles per day, but do what you can do, because it really does help not only how you feel, but your mood and all the things we've talked about, but it does help against the cancer. It does help you tolerate your treatment. So it does improve outcomes. So that's really important.
Yeah. Laurel is asking if there are any certain diets in combination with, of course, the importance of exercise and other alternate methods, but can you speak to any diets that could help?
I don't have any specific diets that I recommend my patients. We know for breast cancer patients, which is who I treat, that low-fat diet is very helpful. But I think it's in some ways common sense. When you look at the typical American diet, we're on the go, we're doing the drive-through at McDonald's, or something that's pre-made or pre-processed. Really, if you can get back to the fruits and the vegetables, the white meats like chicken, turkey, fish. I don't tell my patients that they can't have red meat, but they probably shouldn't have red meat every day. The healthy grains, and then with that, the exercise, the portion control. That's the way I usually counsel. Now, I know Dr. Arntz talked about the culinary medicine yesterday, I believe. And so there is a lot more coming out about that. But if nothing else, the common sense of what you know is good and what you know we probably eat too much of in our country.
Yeah. And portion, and I think portion control is a huge area of opportunity.
It is, and it's hard,
Mm-hmm.
you know. Mm-hmm.
Any other questions or comments for Dr. VanderWoude? Thank you so much for your presentation.
Yes, I just want to wrap up really quickly and just talk about the other things on this slide, just because some people may say, well, she didn't really talk about what I see there. So the sexual dysfunction, you know, certainly both men and women can face this issue as a side effect of either their cancer or their treatment.
Mm-hmm.
Men will often see urologists for help with this. For the women, we have at Spectrum Health, we have the Sexual Health and Menopause Clinic, which has been wonderful for our patients that deal with vaginal dryness and things of some of their treatment or the side effects of premature menopause. The hormonal side effects other than sexual dysfunction, like hot flashes, we have ways of treating them and we can help. Bone health is particularly important, again, for breast cancer patients and prostate cancer patients, but any young woman who's put into premature menopause, you can lose bone health, and that's really important over the long run because your quality of life can be compromised if you develop osteoporosis and have a fracture. That fracture may hurt forever. So there's ways to assess that and treat that. We have a full bone health program at cancer and hematology centers there where we send patients. Cardiac dysfunction, I'll leave that till tomorrow because Dr. Abdullah and Dr. Franey are going to talk about their wonderful program at Lemon Holton Cancer Pavilion, but it's been so helpful for our patients to have them in and optimized prior to starting their treatment if need be, or if something happens during treatment, they can be seen there. Pain clinic, we partner with palliative care services to control pain for our patients. The fertility issue, we have partnerships with the infertility and reproductive endocrinologists in town to help our young patients who need to talk about fertility issues prior to starting the chemotherapy. And lymphedema, which can be a chronic issue for many patients related to lymph node removal for treatment of their cancer. We have a full lymphedema program at Lemon Holton Cancer Pavilion and elsewhere. So there certainly is adequate support. I think as a survivor, if you feel that you're struggling with any of the things that I talked about and you feel like they're not being addressed in the appointment, why not bring it forth and say, hey, you know, doctor, I know you need to ask a lot about certain things and how I'm doing, but what I want to talk about today is I've been excessively fatigued or I am struggling with depression, and don't be afraid to bring that forward so that we can get you to the right people to help. And don't be afraid to talk with your family members. It's a very real experience, some of these things. So we're here to help.
Thank you. Any other last minute questions or comments? Again, thank you for taking the time today and sharing with us. Looking forward to further collaboration. And please, for those of you who have not recorded your attendance, make sure that you do that and take the time to fill out the evaluation and survey, recognizing this is our first virtual Oncology Symposium and an event that we look forward to every year. Would love to hear your feedback and how we can do this better, what we did well for next year. Maybe we'll have a hybrid version. Catherine and I were discussing that a little bit. I always look forward every year to seeing everyone in person, people that we don't necessarily see throughout the year. So we will take that feedback, we'll look at it as a team for next year. And then tomorrow, if you are able to join us for our last session from noon to 2, we will have Dr. Abdallah and Dr. Farani with presenting on cardio-oncology, and Dr. Steensma will be sharing about the benign tumor clinic. Thank you all for your attendance today. Again, thank you, Dr. VanderWoude, and have a great rest of your Thursday.